And we are back. All right. Hope everyone enjoyed their little 5-minute break. I think that's a first in 15 years we've ever been ahead of schedule. All right. So we're going to get going here. And I just want to take a 10-second break to thank Cecilia for and Isla, who you guys don't see because she's behind the scenes. This is a ton of work that they all did. Thank you to Ellen, Brittany, Cecilia, and Isla. But great job. All right. Let's keep going here. We're going to move on to the next society, which is IPEG. So we have 3 presentations from the IPEG meeting. First is Wendy Jo Svedanoff, who's a pediatric surgeon at Nationwide Children's Hospital, and she is going to be talking about a paper bringing utilization of enhanced recovery after surgery, ERAS, protocols for pediatric metabolic and bariatric surgery. So ERAS for bariatric surgery. Their hospital established an ERAS protocol for patients undergoing a robotic sleeve gastrectomy in 2018. And the aim of this study was to compare length of stay in opioid use before and after their protocol was implemented. So that's the first paper. The second paper was Dr. Fulvia Del Conte from Federico University Hospital in Naples with the work Embolization versus Surgical Treatment in Pulmonary Sequestration. Preliminary results of a retrospective multicenter study. As the title says, this is a multicenter retrospective study done from January 2010 to December 2020 that aimed to evaluate and compare the results of embolization and surgical treatment of pulmonary sequestration. And last but not least, Dr. Maxi Marcic, who is the chief of surgery at the Pedro Elizalde Children's Hospital and associate in Gadahan Children's Hospital, and his paper was Challenging Cases of Esophageal Atresia Early in the Learning Curve. How important is specific training? And this study aimed to show clinical and technical performance of a pediatric surgeon, mainly trained through simulation in 2 challenging cases of esophageal atresia and the minimally invasive simulation program used to train the surgeon. So those are the 3 papers. We're going to play a video and go to the polls.
What resources do you use in your hospital to best manage your patients? Where do you or your colleagues go to find your hospital protocols? Where do you go to learn more about the disease you're treating? How do you find the most recent publications? Technique videos, lectures. There are so many places to go to find information. Well, Stay Current Spaces now allows hospitals to have a private space where they can keep all of their key hospital protocols, as well as their favorite other content, such as videos, articles, websites, and lectures, all in one place, in the palm of your hand. This can be shared across your entire department, and now hospitals with spaces can share and view other hospital spaces. Let us know if your hospital or department would be interested in learning more about a space.
All right, and we're back, and we have a winner, pretty dominant winner. So let's see, it's Dr. Fulvia Del Conte, who's presented the paper on embolization versus surgical treatment in pulmonary sequestration. So let's roll that video, and we'll bring Dr. Del Conte in into the meeting.
Dear colleagues, embolization versus surgical treatment in pulmonary sequestration. Results of a retrospective multicenter study. The aim of our study was to evaluate and compare the results of embolization and surgical treatments of pulmonary sequestration in pediatric patients. There is still no consensus on treatment. 3 pediatric surgery units and 4 pediatric cardiological units were involved into the study. Patients younger than 3 years old who received embolization or surgical treatment for pulmonary sequestration between January 2010 and December 2020 were included. Data regarding preoperative workup, demographics, intra- and postoperative detail and follow-up were collected. All the procedures were performed under general anesthesia. Thoracoscopy was performed using 3 or 4 trocars, with the first one placed on the anterior axillary line with an open technique. Percutaneous arterial embolization was attempted by transfemoral approach in all cases. An angiography was performed to identify the aberrant artery, which was cannulated and closed by Amplatzer vascular plug devices. 85 patients were included and divided in 2 groups. Group 1, thoracoscopy with 51 patients. Group 2, embolization with 34 patients. No difference were found in sex distributions and infra- and extralobar sequestration distribution. Prenatal diagnosis was significantly higher in G1 as well as symptomatic patients. There were no differences in procedure time and intensive care unit stay after procedure. Hospitalization was significantly shorter in G1 because 24 patients were treated as day case surgery. Conversion to open was necessary in 5 G1 cases. 3 hybrid lesions were found in G1 patients. 2 G1 patients were previously approached by embolization. In G1, follow-up was based on clinical examination and chest X-ray. Only G2 patients perform MRI or CT scan to check the complete involution of the lesion. At 1 year follow-up, 1 G1 patient requires surgical revision after 2 weeks due to an infected infralobar sequestration. In 1 G2 patient, it was impossible to complete the procedure, and the patient was addressed to the surgeon. All symptomatic patients become asymptomatic at the 1 year follow-up. But at the long-term follow-up, only 6 G2 patients perform imaging. 2 of them require a reintervention due to recurrences. Only 1 of them was symptomatic. In conclusion, we can affirm that surgery and endovascular embolization are both effective and safe treatment for pulmonary sequestration. The main difference is that surgical approach allows to remove the lesion, avoiding the need to monitor pathological tissue and its complete involution over time. Surgical approach, in our opinion, must be the preferential choice, especially in case of intralobar sequestration or doubt of combined lesion. Embolization must be used in case of severe shunt or heart failure, and in this case, we recommend a long-term follow-up supported by imaging. Thank you for your attention.
Thank you for the paper. We have Dr. Del Conte. Thank you for joining us. I love that paper. I actually really liked your conclusion because it was a very measured response there. I just have a question.
Sorry,
hello, can you hear us now? I think there's a delay.
Yes, yes, now, yes.
Yeah, there's a bit of a delay, probably 10-second delay. One question I have is when we look at ovarian torsion, we used to remove them because we thought it was all dead because it looked dead. But then we find that actually, although it looks dead, we know that over time there's viability to the ovary. Is the same thing true here, that you do the imaging and it looks like you've ablated the sequestration, but in fact, if there's any malignant risk in the future, that may not have really been destroyed. So I guess along your recommendations, you'd have to keep following it. So I'm not sure if it's much of an advantage. I'm curious of your thoughts about the accuracy of assessment of viability after embolization.
Yeah. So in our study, only 6 patients of the embolization group performed the MRI at the long follow-up, and within them 2 presented a recurrence. So we think it's very important to perform it in all patients to really check the complete involution and to check that not a recurrence can become again. In other study, that was not performed. So that's the big difference. And that's the big difference also with the surgery, because with surgery, we don't need it. So the follow-up, it's quite important in patients who perform the embolization. And it's invasive. So also if the intervention was less invasive than our surgical intervention, the follow-up, it's heavy also for the parents, because they still remain with the doubt that the lesion it's not complete, disappear.
I guess one of the, I don't know, Tony, if you have a comment or question, or we can go to the audience. Ellen, were you about to read some audience questions?
Yeah, I was just about to ring the bell too. It's about time, but just one quick question, I guess, from a couple of people are asking about kind of this risk of malignancy in the lesions, and if you just embolize them, you need to biopsy, or what's the thoughts there? And
also, regarding that, is the need for follow-up, this is Miguel was asking, for life. Is it a lifelong need for follow-up? Tony, we'll get to your question after that. Fulvia, can you hear us? I don't know. I think there's a delay.
Yeah, sorry, I can't tell. Yes. Okay. Can you repeat the question?
Let's do this. Tony, why don't you go ahead and ask your question?
So I don't know the latest statistics, but I know that sequestrations have a very, very low malignancy rate. So my question for you, if you're going to have to follow these kids up for a long time, why would you just do nothing rather than embolize, especially if there's no vascular issues related to the flow into the sequestration? I, for one, prefer to remove them because of the perhaps minute risk of malignant transformation.
Yeah, at the conclusion, we concluded that we suggest that surgery is better for that problem. You have to follow the patients in all cases, because also if it's a small rate of malignancy, you have in all cases to follow it. And embolization can not resolve the problem. So you have to reserve it only in case you can perform surgery.
Perfect timing. All right. So interesting. I'm learning here from Paul Losty, and I was always under the impression, I know that we've debated this so many times, that sequestrations are a minuscule chance of malignancy, but I always thought they had a chance of malignancy, and I think we're hearing from Paul that it's close to zero, which I did not know it was close to zero. I thought that there was malignant potential of sequestration. But great discussion, great conversation. I just learned a lot, so thank you, and we're gonna move on to the next section.
Thank you.